Good morning. Post-thrombotic syndrome. This is my disclosure slide. I don't have any disclosure apart from a grant I received from Zonnewey doelmatigheidsonderzoek in the Netherlands, which is a cost-effectiveness research for the ideal DVT study, which I will discuss in this presentation. Post-thrombotic syndrome, or PTS for short, is a chronic condition after deep vein thrombosis which occurs in at least 30% of patients. The ranges of incidences are very broad because of the localization of the thrombus. The higher the localization of the thrombus, the higher the risk for PTS, but also because of the different diagnostic strategies that are used for the diagnosis of PTS. PTS reduces the quality of life considerably. Even with mild and moderate PTS, there is a significant reduction in quality of life, and in severe PTS, the quality of life is reduced to the level of chronic diseases such as chronic heart disease. And last but not least, that PTS incurs significant costs, and those costs are mainly driven by hospitalization and treatment of venous ulceration, which occur in 4 to 12% of patients. And to give you an idea for the cost, for the United States, this amounts to $200 million per year, just for the direct cost of hospitalization. And the indirect costs, just as the job absenteeism, are not even in this cost. So it's of paramount importance that we prevent this syndrome from happening. And for that, we have to know something about pathophysiology. And we think there's two major causes for the disease to happen, and those are the process of resolution of the thrombus, which is an inflammatory response, a bit more like wound healing, which will give collateral damage to the vein wall and also to the valves, leading to fibrotic vein walls and fibrotic valves. And fibrotic valves will not approximate as well anymore and lead to reflux. On the other hand, when the thrombus does not resolve, you have a persistent venous outflow resistance, which also will lead to venous pressure, together with the fibrotic vein wall, which is not as elastic anymore, which will add to the problem. So those two together, or one of the two, will lead to venous hypertension, and venous hypertension will induce the end organ manifestations we know as PTS. The end organ manifestations in PTS are a bit like the end organ manifestations in chronic venous disease. They're both based on venous hypertension, which leads to low shear stress, which prompts leukocytes to adhere to the endothelium and to migrate and end up in the perivasculature. And there they will, through the pro-inflammatory mediators, activate nociceptors, leading to pain, which is a central symptom in post-thrombotic syndrome as well as in chronic venous disease. And on the other hand, the high venous pressure will be translated to the microcirculatory and lead to leakage and edema. And edema, together with leukocyte stasis, will lead to inflammatory reactions in the subcutaneous tissue, leading to the skin problems of patients with PTS. So the clinical manifestation of patients with PTS is based on two main factors, pain and edema, and the edema will eventually lead to, together with the inflammatory reaction, to skin problems. And you see two examples of this on the slide on your left-hand side. You see the non-reversible lipodermatosclerosis, which is a fibrosis of the subcutaneous fatty tissue, which is a very restrictive process, very painful. So how do we diagnose PTS? And that's the main problem still, even after a subcommittee meeting in 2008 where the Villalta score was chosen to be our diagnostic tool, but still with the lack of a gold standard laboratory test or imaging or functional test, we do not really know who is really having PTS and who is not. And there's many scores who are still being used, and there is really poor agreement between the scales. The Villalta score, as I said before, is our preferred score, and it has a lot of advantages. It captures subjective symptoms of the patient as well as objective signs. It follows the severity of the disease, so you can follow a patient in time, see whether or not the disease gets any seriouser. And it is also very easy to apply, and it has a good inter-rater reliability, especially for the objective part. So why is it that there are still a lot of papers published with other scores than the Villalta score? The CEAP score is a score preferred by phlebologists and angiologists because they say it captures the PTS better than the Villalta score. There is no subjective signs in there, and it shows what the etiology of the disease is, where the anatomy distribution is, and what the dysfunction is really. But it's not what we have agreed upon in the ISTH sub-meeting. We borrowed more from the chronic venous disease, and one of those things is the use of elastic compression stockings, which have been used for longer periods of time in chronic venous disease to alleviate symptoms of pain and edema. And it was first used by Brandjes in a randomized controlled trial to see whether or not it could also prevent PTS. And he found that when randomized to no treatment at all, there was a relative risk reduction of more than 50% when using elastic compression stockings with a compression rate of 30 to 40 millimeter mercury. So that was a very good reduction of PTS, and Brandoni modeled a trial really after this trial to see whether or not this finding was true, and he found essentially the same thing. So together they found an absolute risk reduction of about 25%, which is a number needed to treat of only 4 to prevent PTS by elastic compression stockings. So how can we explain this finding? Why would elastic compression prevent PTS? Well, the compression, the outside compression, will reduce the amount of capillary leakage and inflammation in the subcutis, and it also will reduce the vein diameter. And here you see a 3D reconstruction of a MRI, and it shows clearly in the lower panel that with compression, even with low compression, you see the diameters of the deep venous structure are very much diminished. And a smaller diameter leads to a higher flow of fluids, which is shown in another study in which they have looked at the ejection fraction in relation to elastic compression. And you see that the higher the compression applied, the better the ejection fraction is. And actually, at a compression of 30 to 40 millimeters mercury, you have an ejection fraction into the normal range. This could lead to less edema, less inflammatory reactions in the subcutaneous tissue, but could it also be of importance in the resolution of the thrombus? And there's an animal experimental work of Cooley, who has made a model, a mouse model, in which he induced the thrombus and ligated the femoral vein partly, so that he induced a situation of reduced flow. And you see that in the early stage, in the normal flow model, the thrombus is, the resolution is really going quite well, while in the reduced flow model, the thrombus resolution is hampered, and you see a lot of inflammatory cells in the the vein wall. And in the late stage, you'll see that the normal flow model has a completely resolved thrombus with minor vein wall changes, while the reduced flow model shows still thrombus. So maybe the application of elastic compression in the acute phase could also influence the thrombus resolution. Two studies show that maybe this is also a time-dependent effect, because the study by Ginsberg started compression only 1 year after the deep vein thrombosis, and he found no difference between the patients with elastic compression stockings and patients with placebo stockings. The good news, however, is that the PTS rates were very low in the study, so perhaps not all patients need stockings. And the other study from Aswanden, who looked at the prolonged duration of elastic compression after 6 months, also did not find any differences between the two groups, so also indicated a time-dependent effect. Then there was a big surprise at the end of last year when Susan Kahn presented her stocking trial and found in a comparison between elastic compression at a therapeutic degree of 30 to 40 millimeter mercury versus placebo, no difference. And she presented the data with the Ginsberg score, which is a very simple score based on just 2 items, pain and edema. And pain is then the special kind of pain that we find in venous disease, and edema, which would be present after 6 months after the deep vein thrombosis. But still, it was puzzling that she did not find any difference. She also presented the data with the Villalta score, and what is really surprising is that with the Villalta score, the incidence of PTS is far higher than with the Ginsberg score, and it's the same population. So that makes you wonder whether there is something in the diagnostic procedure that does not really add up here. So how do we interpret this finding? First of all, the study compared against a placebo control, and it is thought that because of the Villalta score has a subjective part, some patients could have PTS only based on the subjective part of the Villalta score, and perhaps with a placebo-controlled trial you could teeter those out and get the real effect, but you would expect then the effect to be like 20 or 30% lower than the effect that was found by Brandoni and Branches. But she didn't find any, and it's not likely that it's just a placebo effect that accounts for this loss of effect. The other fact is that the compliance rate was really low in this trial. At 24 months, there was a compliance of only 55.6%, and compliance was defined as wearing the stockings at least 3 days a week, while in the other stockings by Brandoni and Branches, the compliance was far higher, 93 and 87%, and it was defined as wearing the stockings for at least 80% of the time. So there's a difference there. If you don't wear the stocking, it won't work. And last but not least, misclassification cannot be ruled out, because there can be random misclassification of the diagnosis, which will lead to underestimation of the effect. And this may be very likely because the Ginsberg score only found about 13% of patients had PTS. And with the Villalta score, we find that it's 52%. It's a major gap. So I think the stockings are still open for evaluation, and perhaps it's also important to look into the individuals who really benefit from the stockings. So that's what we did. We performed a management study in which we tried to individualize the wear of stocking based on the Villalta score. And we found that in the follow-up we could define patients at a low risk of PTS and patients at a high risk of PTS at a very early point in time. And you see that there's little patients in the high-risk category and a lot of patients in the low-risk category. But if we would have used just one Villalta score to make this decision, we would have missed out on 12% of patients who were moving from one severity score to another throughout the whole follow-up. So we used 2 scores with 3 months apart to make the diagnosis. And we found that about 50% of patients needed their stockings for longer than 1 year, and it did not have any implication on the cumulative incidence of PTS, which was about 21%, very much comparable to the percentages found by Prandoni, and we used the exact same diagnostic procedure. So, because it was a management study, we modeled a randomized controlled trial, a non-inferiority trial on this trial, and this has been started in March 2011. 650 patients are included in this trial, and we'll look at the difference between individualized stockings therapy against the normal long-term stocking therapy. And we'll make sure that we assess compliance very well. We will assess compliance at 5 visits and 3 telephone calls to make sure that patients stay in their treatment arm. It's, however, not very nice to have to make a decision who is at risk for PTS and who is not based on a diagnostic score. It would be better to have a predictive score, but we don't have prediction rules yet. We do know a lot of risk factors for PTS, and most of the risk factors revolve around hypercoagulability. And also, if you look at patients with PTS, you see that their risk for recurrence is also higher. So there must be something with coagulation in there. And many researchers have thought that and have looked into inherited thrombophilia as a risk factor, acquired thrombophilia as a risk factor, but none of them found any associations with PTS. The only coagulation parameter that is associated with PTS is the dimer. But that there is something in coagulation is also shown in studies in which was looked at the anticoagulation therapy, and this is an example from the reverse study in which they saw that if patients have an INR below 2 for more than 20% of the time in the first 3 months of treatment, they have a higher chance of acquiring PTS. And this was also seen in previous studies by Van Dongen and Ziegler. And also a study by Hull, the Home Light study. He asked patients after 12 weeks of treatment with low molecular weight heparin for signs and symptoms of PTS, and he found also a risk reduction compared to normal VKA therapy. And very recently, a study was published by a South Italian group of people who had done a management study in which they compared therapy after the usual therapy, so a prolonged therapy, with either no prolonged therapy with sulodexide, which is an oral compound, a bit heparinoid-like, and aspirin. And they found that sulodexide had a significant reduction in recurrent thrombosis and in PTS, but for aspirin they didn't find this. And it could be because this is a management study and there's a lot of bias in this study that the outcomes are as they are, but they also point in the direction that heparinoids in the earlier stage could be of benefit in the prevention of PTS. It's all thought that the thrombolysis is impaired when the thrombin is not inhibited well enough. So if there is enough thrombin formed, it will activate TAFI, and that will prevent plasminogen being converted into plasmin, which will impair the thrombolysis. So thrombolysis is important, and for PTS it is also important to remove the clot as quick as possible, and that's the open vein hypothesis, in which we think that fast removal by, for instance, thrombolysis can prevent PTS. And there is evidence for this. This is a review in which it's shown that the better the lysis is, the lower the PTS scores are. It shows also that catheter-directed thrombolysis is also associated with higher bleeding rates, but the bleeding rates in this case are just local bleeding at the insertion opening of the catheter. And a very recent randomized controlled trial by Enden showed that there is better patency at 6 months after thrombolysis, and 2 years follow-up shows that there is an absolute reduction of 14% in the incidence of PTS, which she showed was a cost-effective reduction with a number needed to treat of 7. And you can also appreciate here that the bleeding rates are lower, and that is because nowadays pharmacomechanical treatment is used so that the thrombolysis does not take as long as before, when it was only the lysis fluids that were used. Another advantage of catheter-directed thrombolysis has been that in many cases in the iliofemoral tract there are anatomical lesions leading to thrombosis and rethrombosis, and they can be identified during the thrombolysis period. And you see here pictures of a iliofemoral vein in a 36-year-old lady with a thrombosis after childbirth, and with angioplasty and stenting the flow was restored. So it also has another advantage to do invasive treatment. So the future areas for research in the field of post-thrombotic syndrome should be that we better define patients at risk for PTS, and that would be the development of risk scores, better diagnostic procedures, and also the pathophysiology of PTS should be elucidated more. So we should do more research into biomarkers and imaging, and last but not least, we should evaluate the effectiveness of different treatment options, and that those are prophylactic and curative treatment options for different patients, and preferably for individual patients. And with that, I would like to conclude and invite you all to Maastricht for the Consensus Conference on Thrombosis, February 2015. Thank you.
Thank you very much, Dr. Ten Kate. There is now room for 1 or 2 questions. Are there any questions from the audience? Maybe I can start. So, what should be the next study in the elastic stockings story?
Well, we have to wait what my study is going to present, whether or not individualized treatment will be beneficial. So if this shows that PTS rates will be as low as the rates in the studies by Branches and Prondoni, we'll know that there is a place for elastic compression stockings. And what was your question?
Or whether there should be another study started on this issue.
I think definitely. And I think the primary study we should have was a treatment study.
In your study, how often did you change the compression hosiery?
We do that once every 6 months.
Okay.
Okay, if there are no further questions, thank you again for a very clear presentation.